And now,
We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Saditi on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee with Amogs MTP and Family Welfare Committee with Latur, Parbani, Jalna and Islampur societies. And today's episode is 37. So it's my privilege to introduce the convener of today's webinar, Dr. Monica ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalya Nursing Home and Atharva Fertility Center. I welcome you, ma'am. It's my honor to introduce the other convener of today's webinar, Dr. Rachna Jaju, ma'am. Ma'am is the chairperson of MTP and Family Welfare Committee, Amogs 24 to 26, organizing secretary of MTP National Conference 2024. I welcome you, ma'am. And it's my privilege to introduce Dr. Prajakta Gude, ma'am. Ma'am is the director of Maher Maternity Hospital and Nucleus Test Tube Baby Center, Udgir. I welcome you, ma'am, and I hand over the session to Dr. Rachna, ma'am.
Good
evening, one and all. I welcome you all on behalf of Emergency Obstetric Committee, Amogs, and Amogs MTP and Family Welfare Committee for this webinar on MTP contraception and emergency obstetrics. And it is my honor and privilege that we have Amogs President Dr. Kiran Kurtukoti sir as our chief guest, and the guest of honor Dr. Ajay Mane sir, past Vice President Foxy, and Dr. Kalyan Varmade sir, who is President IAGE. So it is a great moment for us that we are joining together for this webinar. And along with me, the convener is Dr. Sneha Bhuyar ma'am. And ma'am is continuously doing this webinar series and giving us so much of education on all parts of obstetrics. So we are very thankful that ma'am has collaborated with us for this webinar. And I would request Kiran sir CV first.
no, forget about CV. Okay. Rachna, thank you. Thank you. At the outset, let me congratulate the MTP committee as well as the Family Welfare Committee and Dr. Sneha Bhuyar's committee, that is the Emergency Obstetric Care Committee, who have joined together and formulated this particular program. Really a very nice program. Heartiest congratulations to Dr. Bhaurao Yadav, because sir will be taking over as the president of Latur OBGY Society, and this is the first webinar after Kalyan has become the president. On behalf of Amogs, I would like to convey our best wishes and congratulations also to Dr. Kalyan Barmade for being installed as the president of IAG. Well, having said this, really appreciate Sneha, because this is your Acha Kalyan. Congratulations, sir. We have officially congratulated you, huh? Before joining. So as far as Dr. Sneha is concerned, Sneha, really you have been doing a marathon work, and I really appreciate the enthusiasm by which you are working for Amogs. And thank you so much. Please keep up the excellent work, and I'm sure that you will succeed in whatever your goals are for this particular year. Having said this, this particular topic, that is MTP, family welfare and everything, is very close to my heart, because when I was the chairperson of the MTP committee Fox in 2009, me and Ritu Joshi have worked quite closely. We have organized many webinars, not only webinars, but many physical conferences and workshops, not only in Maharashtra, but also in MP, UP, Bihar and Rajasthan. So really, it's a great moment for me that Ritu will be joining. So also congratulations that I would like to hear what Dr. Meena Madam would be saying. And also Gorak, and of course we'll keep on with Dr. Sneha, who will be moderating the further sessions. So my best wishes to all of you, and I would request Dr. Rachna, please get on with the further sessions.
Yes, thank you so much, Dr. Kiran, for giving us a free hand for that indeed inspires us, motivates us for going ahead. So thank you so much once again. So friends, as you know that we have been working for Amogs Emergency Obstetrics Committee, and for this committee we are organizing sessions on emergency obstetrics, not only to reduce the maternal mortality and morbidity, but also the perinatal morbidity and mortality. And yes, definitely MTP and family welfare has an important role in all this also, and that is why we have collaborated with this committee. So I welcome once again the Amogs president and of course our guest of honor, Dr. Ajay Mane, the past vice president of FOXI, our dear friend Dr. Kalyan Baramde, whom we are so proud of, and hearty congratulations to you, Kalyan, for being installed as the national president of IAG. We are really very proud of you, Kalyan. Welcome to this program. So I also welcome all the esteemed speakers, who have, who actually have the benchmark in this field. Dr. Meeta Gupta from Jammu, and of course, Dr. Ritu Joshi, the past chairperson of the Family Welfare Committee of FOXI. And Meeta will be speaking on LARC, and Ritu will be speaking on the postpartum newer contraceptives, and I will be moderating the panel discussion on obstetric hemorrhage. I'm very happy to have Dr. Gorak Mandrupkar as expert for this panel discussion. And with this, I welcome, I think Ajay is yet to join. So I request Dr. Kalyan Baramde, who is also the past chairperson of the Public Awareness Committee, and of course, so many posts and positions he has to his credit. Without wasting much time, I think we would like to listen to you, Kalyan, for your precious work. Over to you.
Thank you, Dr. Sneha Madam and Dr. Rachna Jaju for this opportunity. Dr. Kiran, under aegis of Amogs and our active president, Dr. Kiran Kurtakoti sir, you are doing these webinars across Maharashtra, and there are so many listeners out of the Maharashtra also. So we are proud of Dr. Sneha and Dr. Rachna for arranging such good webinars. And I'm proud to say that our Emergency Obstetric Committee, which is headed by Dr. Sneha Boyar, is doing a lot of work, and we wish her all the best for her future endeavor, that she should become Vice President of FOXI this time without fail. I thank Dr. Rachna Jaju, who is a good friend of us, and she's doing a lot of good work in Family Welfare Committee of Amogs. She's from my place, so we have a special bond that she's a very good friend of us, and she's a pride of Latur, who is doing a lot of good work. So I wish all the best to Dr. Rachna Jaju also. About this webinar, this is a Latur, Parbhani and Islampur Committee's webinar, which has been conducted by Amogs Emergency Obstetric Committee and Family Welfare Committee, which are, we are going to concentrate today on newer contraceptive options like LARC, and also obstetric topics like obstetric hemorrhage, which is very important topic in day-to-day obstetric practice. So I wish Dr. Meeta, Dr. Ritu, Dr. Gorak, and Dr. Sneha Madam all the best for this webinar, and I thank Dr. Sneha and Dr. Rachna for this opportunity. All the best. Thank you.
Thank you so much, Kalyan. Thank you so much. And of course, I really make a humble appeal. Not only your votes, but your prayers and best wishes are also required for me. So thank you so much once again. And over to you, Dr. Rachna, for...
Thank you so much, Kiran sir, for always being there as a backbone and supporting us for all our endeavors, giving us a free hand to do such webinars. And Kalyan sir, of course, he has always been very inspiring, and he himself is such a big pride for us Laturkars. And it is our privilege today that this webinar we are hosting together along with the societies of Latur, Jalna, Islampur and Parbhani. So now this webinar is more important for me because my Maher, माझा Maher Jalna hai, and my aunt has also joined today, Dr. Aarti Mantri. So she was one who was a figure for me where I thought to become a doctor and a gynecologist. So this webinar is all the more special to me. And we welcome you all, and I think we can move ahead with the scientific session now. So for the first session, the topic today is postpartum newer contraceptives. And for this, we have chairpersons Dr. Seema Porwal Madam, who is president of the Islampur OBGY Society. We welcome you, ma'am. Ma'am is president of the Islampur Obstetric and Gynecological Society. She is past president of the IMA Islampur branch.
can I interrupt you, Rachana?
Yeah,
Actually,
ma'am,
Dr.
sure.
Ritu will be after 6 p.m. So we will have Dr. Meeta's talk first.
Okay. So,
Ritu, welcome back.
Thank you, Karan. Lovely to see you.
Same
And
here.
I'm so sorry that can I finish off with 2-3 patients fast and join you people at 6 o'clock.
That is what the
Okay.
message I'm giving.
Thank you. Thank
Yes,
you.
Ritu. We'll see you in
Okay.
some time.
Okay.
Yeah. So we can continue with Dr. Meeta. Rachana, go.
yeah. So, can we share the CV for the chairpersons, Dr. Prasad Magar sir and Sujitra Balchandra madam? They have joined in. Dr. Prasad Magar sir is working as a consultant at Parbhani, Maharashtra. He has special interest in bad obstetric history, medical disorders in pregnancy, infertility and high-risk obstetrics, and he is president of the Parbhani Society since 2020, up till 2022. We welcome you, sir. Our next chairperson today
Thank
is
you, madam.
welcome you, sir. Dr. Sujitra Balchandra madam. She is a consultant gynecologist practicing for the
Yes,
last
sir.
35 years. And she has special interest in high-risk obstetrics. And it was a great honor for Latur Society, as madam has received Lifetime Achievement Award yesterday, that is on Sunday, by Latur OBGYN Society. So it is our great honor that madam is here with us. And I would request Balchandra madam to introduce our speaker today, Dr. Meeta Gupta.
Hello.
Yeah, ma'am, you're audible.
Yeah. Dr. Meeta Gupta, she is MS, FICOG, FI, MSA, MNA, MS. She is Dean Academics, Professor and Head of the Department of Obstetric Gynec in AIMS, Vijaypur, Jammu. She is winner of Women's Health Researcher Award in Senior category. She has done advanced courses in medical education. She is teacher for last 18 years with special interest in adolescent health and high-risk pregnancies. She had many publications to her credit. Welcome, Madam Meeta Gupta.
Thank you so much, ma'am. And if the permission of the chairperson is there, so can I start with my presentation?
Yes, Madam.
Thank you so much. At the onset, it is an honor to be here. And thank you, Sneha, ma'am. I'll be just making it okay. For giving me the honor of being present over here. And especially because Gorakh sir have been one of my mentors and sir is also here. So thank you, Sneha, ma'am, for giving me this opportunity. I hope my screen is visible.
Yes.
Ma'am. Okay. So greetings from AIMS
Yes,
Jammu.
sir.
Thank you, ma'am. So today I'll be talking about the long-acting reversible contraceptives, that is LARC. So if we look at the entire spectrum of contraceptives that are available, the top is the LARC, that is also known as tier 1 contraceptives. And it is the failure rate of LARC is actually similar to the permanent sterilization methods. The LARC failure is about less than 1%, one pregnancy per 100 women in a year. So they are parallel at par to the permanent sterilization methods. LRC includes the copper T, the levonorgestrel releasing copper IUCDs, and as well as the implants. I will only be restricting myself to the copper T and levonorgestrel releasing hormones. So they are tier 1 methods because they are reversible. They are also known as a forgettable contraception because once inserted, we can forget about them. They have a typical failure rate of less than 1%. Highly acceptable. There are more chances of continuation if the patient is well motivated, gives highest satisfaction level. And in the Western countries, it is used as a contraceptive method for adolescents also. So currently, the FDA has approved 3 types of IUCDs. The Lipi loops, that is absolute. The copper T IUCD is available into various parts, that is a Paragard, that is 380A, 375 multilode, or a copper T 200. LNG IUCDs is available in the market in worldwide in 3 strengths, that is LNG 52, Mirena, which is commonly available in India,
LNG 19.5 microgram, that is known as Kylina, and LNG 13.5 microgram, JDES, is also available in other parts of the country. So if we come to copper IUCDs, we have to understand that it is a T-shaped copper T with varying amount of copper wire present around the vertical and in some places in the on the horizontal arm also. In some countries, we have also started use of non-T-shaped copper IUCDs, but not very prevalent. If we look at the mechanism of action, it acts main by preventing fertilization. If very rarely fertilization does occur, it inhibits implantation. It acts as a presence of foreign body in the uterine cavity, and the copper released is in the endometrial cavity causes biochemical and morphological changes, which leads to adverse effect on sperm motility, transport, and the acrosomal reaction. As a result, the fertility chances are very rare. It also enhances the inflammatory response inside the uterine cavity, as well as in the luminal fluids of the genital tract. They are toxic for the sperm and thus reduce the ability of the sperm to penetrate the cervical mucus. The tubal transit is affected, as well as there are increased chances of apoptosis of the released ovum. So the fertilization window is decreased. But if you look at the evidence, there is no evidence that ovulation is impaired in copper T IUCD users. It has been also one of the other indications is as an emergency contraception for copper T, and it is seen that it is more than 99% effective if used within 5 days, that is 120 hours after unprotected sex. It has the additional benefit of being used as a long-term reversible contraceptive if initially used as an emergency contraception. So coming to the second, that is the levonorgestrel releasing IUCDs, we have 3 variants present. The Mirena, that is known as LNG 52 microgram IUCD release. It releases 20 microgram of LNG per day initially, which diminishes to over 10 microgram per day after 5 years. 2 variants are not available in India, but I have just put it for the reference. If we look at the mechanism of action, we know that the progesterone reservoir is present on the vertical stem, and this progesterone is released through a very rate-limiting membrane. As a result, it causes a very weak foreign body reaction in the body. The endometrium, because of slow release of the progesterone, causes endometrial decellularization and glandular atrophy. The primary mechanism of action is on the cervical mucus because it alters the amount as well as viscosity of the cervical mucus, thus causing barrier to the sperm penetration. Ovulation is also likely to be inhibited in some, but it is preserved in major participants because of very low release of progesterone. The estrogen and progesterone receptors are suppressed in the endometrium. As a result, the bleeding pattern changes, and this causes the contraceptive effect. It is said that use of either copper T or hormonal IUCD reduces the risk of endometrial cancer, and the proposed mechanism is different in both of them. In copper IUCD, there occurs a reduction in endometrial mitosis and estrogen receptor concentration, whereas in the LNG IUCD, there occurs a down-regulation of estrogen receptors, the low endometrial cellular proliferation, endometrial decellularization, and ultimately atrophic changes. As a result, it protects against endometrial hyperplasia and endometrial polyps in women on tamoxifen. It has also been used in women who are having hyperplastic polyps, so it can be used for prevention in these patients. Do they give a protection against cancer cervix? The data is very challenging to understand because an analysis of 26 epidemiology studies show that there was a significant reduction in all types of cervical cancers who were using IUCDs, but this reduction was not seen in women who were high risk for having or who had a positive for high risk HPV DNA virus. So it is said that they offer protection by cellular immunity only. Now coming to the non-contraceptive benefits of LNG IUCDs. It has also been approved for treatment of heavy menstrual bleeding. It causes reduction in menstrual blood loss. As a result, it improves the hemoglobin levels as well as quality of life. Many women have cancelled their chances of hysterectomy by use of IUCDs. The dysmenorrhea improves. There is also improvement in symptoms of endometriosis and adenomyosis. But please remember, it is not associated with any reduction in the fibroid size. Till date, no study has been published for use as a postcoital contraceptive, and it has not been recommended for emergency contraceptive at present. Coming to the effectiveness, once inserted, it is not dependent on the user. So the patient has a very high continuation rate, very low chances of failure as compared to laparoscopic permanent contraception. The larger the copper area, the lesser is the failure rates. And it has been said that copper T380A is one of the most effective IUCDs that are in use. But please remember that use of barrier method condoms is still recommended for protection against the various sexually transmitted diseases. So if we look at the indications, in case of absence of contraindication, it can be offered to everybody and anybody who are seeking effective, reversible, coitally independent method of contraception, a longer-term contraceptive, which can be forgetful and is also an invisible method. It has less adherence because it is less demanding, and somebody who does not want to use hormones as a contraception. It is specially indicated in women who have any contraindication or sensitivity to estrogen as a component in oral contraceptives, and can be used in breastfeeding in all breastfeeding females. So if we come to the absolute contraindications, pregnancy, pelvic inflammatory disease, puerperal sepsis, pelvic tuberculosis, distorted uterine cavities, unevaluated abnormal vaginal bleeding, a known case of cervical and endometrial cancer, a malignant trophoblastic disease with persistently elevated beta-HCG levels and active intrauterine disease, or the patient has a known progesterone receptor positive breast cancer. These are the category where IUCDs are an absolute contraindication. Coming to the category 3, where a lot of counseling is required because the benefit outweighs the risk. These are patients who have a past history of progesterone receptor positive breast cancer of more than 5 years, but now are treated. It is a severe decompensated cirrhosis, hepatocellular adenoma or malignant hepatonoma, a complicated solid organ transplantation, and somebody who is a postpartum of 48 hours to less than 4 weeks. In these, a lot of counseling is required, and we may insert with IUCD. So before we have decided the indication and the contraindication, before IUCD, an informed consent has to be taken. Lot of counseling regarding the risks, benefit, and alternate method of contraception has to be given to the patient. The potential side effects, especially the changes in menstrual cycle, has to be informed to the patient. And we have to remind to the patient that they do not protect against the sexually transmitted diseases. So once these things are done, a cervical inspection and a bimanual examination has to be done. The uterine position and size, as well as the uterine and cervical abnormalities noted. If the patient is present with us for IUCD insertion, we can take it as a window of opportunity to screen the patient for any sexually transmitted, but that does not delay the IUCD insertion. So if you look at the systemic, usually many people routinely advise misoprostol, but as per the literature present, routine IUCD placement does not require an routine misoprostol implementation given to the patient. A paracervical block with lidocaine may be used to reduce patient discomfort during placement. And this is all according to the patient individual basis and how much is the patient pain threshold. Routine antibiotic prophylaxis for IUCD insertion is not indicated. The IUCD inserted by a no-touch technique. So to minimize the risk of infection, no instrument should touch any non-sterile surface. The cervix to be cleaned with any antiseptic, ideally iodine or chlorhexidine. The tenicellum is used for gentle traction so that the angle between the cervix and the body of the uterus is straightened. Uterine sounding may be done, but IUCD inserter should not be used as the sound for sounding of the uterus, and the strings should be trimmed about 2 to 3 centimeters beyond the external os. So once we are for a backup contraception, if we are using a copper IUCD, no backup method is used because we already know that copper IUCD also acts as an emergency contraception. But if we are using an LNG IUCD, usually 7 days contraception or a barrier method is advised to the patient to use for next 7 days. So after insertion, the follow-up visit has to be planned for 4 to 12 weeks post-insertion. This is to look for any expulsion, any infection, assessment of the bleeding patterns, assessment of the patient and partner satisfaction, a clinical examination and the string check, and also the opportunity to reinforce the use of condom for protection of sexually transmitted diseases. So she is advised to contact her healthcare provider if the patient does not feel the strings. She or her partner can feel the lower part of intrauterine contraceptive device. She thinks she is pregnant. And if the patient is using a copper IUCD and she becomes amenorrheic, if she experiences persistent abdominal pain, fever, or an unusual vaginal discharge, she wishes to remove the device and plan another pregnancy. She or her partner feel pain or discomfort during any coital activity after insertion, or she experiences a sudden change in her menstrual periods. These are the things that she has to be informed about, that any of these symptoms, if occur, she has to consult her doctor. Now coming to the side effects that we have to inform is bleeding. This is the most common, and especially irregular bleeding and the changes in amount. With copper T IUCD, there is an increase by about 65% in the amount of menstrual bleeding. NSAIDs or tranexamic acid is the treatment of choice to decrease the bleeding. With LNG IUCD, there occurs a reduction in menstrual blood loss, but it usually takes 6 to 8 months before decrease in menstrual blood loss occurs. Unscheduled bleeding, if persists or is associated with pelvic pain, always warrants investigation to rule out infection, pregnancy, cervical or uterine pathology, expulsion, or a malposition of IUCD. Coming to pain or dysmenorrhea, cramping at the time of insertion or first several days following insertion is seen. There may be, we can use NSAIDs to decrease this. Any antispasmodic can be given to the patient. Copper T IUCDs are associated with slight increase in dysmenorrhea, whereas LNG is a treatment of choice for dysmenorrhea. Nulliparous women, if given IUCD as an option, may report more chances of pain or dysmenorrhea after insertion. Coming to the side effects that are more specific to LNG IUCDs are acne, breast tenderness, headaches, and altered mood in the female. And these are all because of systemic absorption of the hormone progesterone. Now coming to the risks that are associated with during IUCD insertion. The first is a uterine perforation, but this is usually related to inexperience of the surgeon, or sometimes in a postpartum female or a breastfeeding female. Infections are most common, but it is very small. And if we take all the aseptic precautions, then chances of infection are markedly decreased. Expulsion is most commonly seen in the first year of use, and the risk factors associated are if the patient gives us a history of heavy menstrual bleeding, dysmenorrhea, young age, atypical uterine shape, any leoma, or a history of previous expulsion. This does not appear to be higher in nulliparous women or associated with any length of the endometrial cavity or use of tampons or menstrual cups in the female. Coming to the failure rate, we already know the failure rate of IUCDs is very less, but ectopic pregnancy, if occurs, first in all, we have to understand that the chances of ectopic pregnancy is very rare because the mechanism of action is by decreasing the chances of fertilization. But if you have an IUCD in place and pregnancy still occurs, then it is more likely that LNG IUCDs are associated with ectopic pregnancy. So coming to some other potential pregnancy complication of failure, it is seen a large retrospective cohort data shows that if a woman becomes pregnant while using copper IUCD, then it is associated with adverse pregnancy outcomes like spontaneous abortion, septic abortion, intrauterine fetal death, IUGR, preterm or preterm rupture of membranes. So if a patient has a copper IUCD and gets pregnant, please remove the IUCD at the very earliest. Sometimes we may have amenorrhea or delayed menses. If a patient has copper IUCD and the patient develops amenorrhea, pregnancy has to be excluded. Whereas with LNG IUCDs, amenorrhea occurs after 6 months and does not require much of evaluation, but urine pregnancy test has to be advised to the patient to rule out pregnancy. So now coming to what are some myths and misconceptions associated with copper IUCDs. IUCDs is not suitable for adolescent or nulliparous women, but the WHO states that age alone does not constitute a medical reason for denying any method to any adolescent. Second myth associated is IUCD increases the risk of ectopic pregnancy. Please understand that IUCDs do not increase the risk of ectopic pregnancy because their mechanism of action is primarily by prevention of fertilization. IUCD is associated with risk of infertility. IUCDs do not increase the risk of infertility. It is said that women who discontinue the use of IUCD in order to conceive are able to conceive within next 6 months. And copper IUCD is not associated with an increase in tubal factor infertility in nulliparous women. Another myth associated is that IUCD increases the long-term risk of pelvic inflammatory disease. It has been documented that the incidence of pelvic inflammatory disease among women using an IUCD is less than 2 episodes per 1,000 years of use, which is very similar to the general population. An IUCD needs to be removed if the patient develops sexually transmitted disease or a pelvic inflammatory infection. Please remember that removal of IUCD is not documented. If the patient can be started with an antibiotic, if she does not respond to the clinical improvement within 48 to 72 hours of appropriate antibiotic treatment, then only chances of removal of IUCD has to be thought over. Otherwise, the patient can take treatment antibiotic and continue using the IUCD. So if you're using one contraceptive and you want to switch over to the second contraceptive from an intrauterine contraceptive device to a hormonal contraceptive, you can start hormonal oral contraceptive 1 week before the removing of the intrauterine contraceptive. If you want to insert a new intrauterine contraceptive, the same can be done at the same sitting. You can remove the old IUCD and insert a new IUCD. Switch from copper IUCD to a LNG IUCD. It can be done at a single sitting, but we have to administer or advise barrier method or abstinence for next 7 days after insertion of an LNG IUCD. From intrauterine contraceptive device to tubal ligation. In this, condoms or abstinence from vaginal intercourse for 7 days prior to tubal ligation has to be advised to the patient. Now coming to some troubleshooting after insertion. So if the patient comes to us with lost string, please examine speculum examination. Pregnancy has to be ruled out, and ultrasound is the preferred method to look for the displaced IUCD. If pregnancy occurs with IUCD in place, then the patient a transvaginal sonography is done to associate the location of the pregnancy. IUCD has to be removed at the earliest. And this patient if the patient continues with the pregnancy, the chances of adverse reaction with IUCD in place has to be counseled to the patient. We have already discussed that if a sexually transmitted or PID develops with IUCD, the patient can be given antibiotic. If she does not improve, then we can think after 48 to 72 hours, then we can think of removal of IUCD. If patient develops malposition, nothing has to be done unless until it perforates the uterine cavity, then laparoscopic removal has to be taken care. If it is embedded inside the IUCD, then hysteroscopic guided removal can be undertaken. So, copper IUCD can be used anytime. No additional contraceptive is to be advised. Levonorgestrel IUCD can also be used anytime, but usually 7 days backup or any method additional contraception has to be advised. In both these IUCDs, bimanual examination and cervical inspection has to be done before insertion of IUCDs. To summarize, IUCDs copper is one of the best because they is also associated with reduction of cervical as well as endometrial, and they can be used for up to 12 to 15 years. LNG IUCD Mirena can be used up to 7 to 9 years, and it is also associated with reduction in endometriosis associated pain and dysmenorrhea, as well as it is associated with decreased chances of ovarian and endometrial cancers. So to summarize, they are the best, or they may be as effective as a permanent contraceptive method. Both the copper IUCDs and the LNG significantly decrease the risk of endometrial CA. The use of levonorgestrel releasing IUCD can be taken by patients usually taking tamoxifen, and which is not associated with any recurrence of breast cancer. The non-contraceptive benefits of LNG are it significantly decreases the menstrual blood loss as well as improves dysmenorrhea. The risk of uterine perforation decreases with inserter experiences, but it is high in postpartum and breastfeeding women. The risk of pelvic inflammatory disease is slightly increased in first month of insertion, but the absolute risk is very low. Nulliparity is not associated with an increased risk of expulsion, and ectopic pregnancy is very rare with IUCD, but if pregnancy does occur, the chances 50%. Any patient who conceives with IUCD in place, early removal improves the outcome, but does not eliminate the risk. Intrauterine contraceptives do not increase the risk of infertility. Immediate insertion, that is 10 minutes post-placental to 48 hours, postpartum or post-cesarean section is associated with higher continuation rate compared to insertion at 6 weeks postpartum. The benefit of inserting an IUCD immediately in postpartum or a post-cesarean section outweighs the disadvantage of increased risk of perforation and expulsion. Insertion in breastfeeding women is associated with higher risk of uterine perforation in the first postpartum year, whereas immediate insertion in post-abortal significantly reduces the risk of repeat abortion. Antibiotic prophylaxis does not significantly reduce the post-insertional pelvic infection, and the risk of expulsion may be slightly higher with immediate placement after second trimester as compared to first trimester abortion. These are the references from which I have taken my presentation. So, thank you.
It's very nice discussion which is said by you, and you are really an authority in delivering all such types of lectures. In your college, do you prefer post-placental insertions in all the patients who are delivering?
Ma'am, we have to counsel because it's a contraceptive. The consent has to be taken. If the patient does it, gives it, ma'am, post-cesarean, immediately we insert it, ma'am, or post-normal delivery.
Achha.
We do insert, ma'am.
Acha. Many times patients say, I have an insertion in the government hospitals, and when they come for checkup, there is no evidence of copper inside. Expulsion rates are probably very high.
Ma'am, it is said that post-abortal or postpartum, the expulsion rates are very high. We are doing a project in which we are following these patients, but actually the problem is, ma'am, these patients do not come back to us. They would probably go to a private setup to get their copper IUCDs checked. So we are lacking of data as the patients who are presenting to us with IUCDs, with lost IUCD in postpartum or post-abortal. That is what is we are trying to look up why these patients are. If you look at the new Kelly's, ma'am, we have a new placement device that is a Kelly's instrument. If you place it with this, they say there are less chances of postpartum expulsion of the IUCD.
Madam, do you recommend tying of some catgut or vicryl to the both ends of cooperative at
No,
cesarean insertion?
No, ma'am. No, ma'am.
Achha.
Ma'am, it's because after removal of placenta, you insert the IUCD and you take out the strings down there. We do not know, ma'am. We do not do, ma'am.
Achha. Many thanks to you, madam. Very nice and elaborate discussion from you also.
Thank you, ma'am.
I would request Dr. Prasad Magar sir and chairperson for this session to give his closing remarks. Dr. Magar sir. Are you there, sir?
Rajna madam, I want to share one experience with regarding the missing property in our government medical college Latur 2.5 years back. Madam, video came to us for removal of the IUCD, and on examination, thread was missing. And by we are thinking about missing thread, so we go for ultrasonography, and to our surprise, it was found that copper was in bladder, floating in the bladder. So with the hysteroscope, same hysteroscope, I have removed this copper by doing the cystoscopy. But actually, in this case, the copper was inserted by the paramedical person in the peritoneum, and it was inserted from the urethra. It is not a case of perforation. There was no scar inside a bladder, but the copper was freely floating inside the bladder. So she don't have any problem for these 2.5 years.
But sir, she should have conceived by that time.
After insertion of the copper the husband was died in 4 to 5 months.
Achha.
Oh.
Okay, sir.
And copper is inside the bladder. I have that video.
Yes, sir. Sir, that is what we have also seen, that if the copper is inserted by any doctor, they are very nice. The patient is counseled very well and the chances of failure or perforation is very mild. If they do it in the by some paramedical staff, probably that is the patients who are coming with perforation or misplaced IUCDs.
Yes.
Sir, till date, we have very few indications where maybe somebody who is an untrained, who has inserted and come up with a misplaced or a perforation. It's not seen in the medical colleges nowadays.
Many times they miss the anteversion and retroversion of the uterus, and that is the reason of perforations and misplaced IUCDs.
Yes, ma'am.
Sometimes they do not negotiate the cavity at all. The copper is inserted in the cervical canal.
Ma'am, this we are seeing more with Mirena because probably it is thicker. So they do not understand. The PGs that is what we are teaching them. Please understand where you're doing the cervical length. So we have an now we have made it a protocol for our college that every time you insert, look it in by an ultrasound and see that the IUCD is, especially the Mirena, because the patient is spending so much for Mirena, you're placing it correctly.
And it is a failure when there are double uteruses, 2 horns of uteruses.
Yes.
I have put in 2 copper for many patients. In both the horns, copper was inserted.
Yes. Really very thankful, Dr. Meeta Gupta madam. It was a delightful lecture with which covered almost all the points, and we are really thankful Dr. Balchandra madam and Dr. Prasad Magar sir for chairing this session for us. Moving on towards the next talk for today, we have chairpersons Dr. Seema Porwal, madam. She is president of Islampur OBGY Society, and Dr. Bhaurav Yadav sir. He is presently the president of the Latur OBGY Society. So, can I have the previous slide? Previous slide. Dr. Seema Porwal, madam, she is president of the Islampur OBGY Society. She is past president IMA Islampur branch. She has received best medium branch IMA Maharashtra award. And she's a practicing obstetrician and gynecologist at Islampur since 1997. She has conducted nearly 18,000 deliveries. That is a huge rate, ma'am. We welcome you here. The next chairperson for this session is Dr. Bhaurav Yadav, sir. First of all, we congratulate sir officially because it is the first webinar we are having with sir, where is president of the Latur OBGYN Society. Sir is MBBS, MD, FIC, MCH, DFP, MNA, MS, FICOG, FICS. He is head of Department of Obstetrics and Gynecology, GMC Latur. He has his own setup, Yadav Hospital and Endoscopy Center at Latur. He is right now the president and he is coordinator of the Jeev Daya Foundation, Texas, USA. Sir has interest in basic obstetrics, office hysteroscopy and NDBH. We welcome you, sir.
Thank you.
And would request the chairpersons now to introduce our guest speaker today.
Good evening. We have Dr. Ritu Joshi. She's going to speak on postpartum neocontractives. She's a senior consultant at Fortis Escorts and Surya Hospital, Jaipur. She was the vice president FOXI in 2014, and she was a past chairperson of Family Welfare Committee FOXI from 2009 to 2012. Welcome, madam. Welcome for the talk.
Why it is not coming? Hello? Can
Hello,
you people hear me?
Yes, ma'am.
Should I share the screen?
Sure, ma'am.
Yes, sharing the screen. It'll take me a minute. But it's not coming.
We can see your desktop, ma'am.
I can't see my own desktop.
I think the Zoom window is minimized. We can see that here.
Please open the PPT, ma'am.
One second. I'm opening the Zoom window.
Minimize this
Open
window,
the
ma'am, and open the PPT, ma'am.
One second. I don't know the Zoom. 1 minute. Okay. Now, where is the PPT? Can you see it now?
Yeah, Ritu, just make it full screen.
Yeah,
We can
yeah,
see
yeah.
you
I'm
well.
just doing that. Can you see it now?
Yes, ma'am.
Huh? Okay.
Yes, ma'am.
So we're going to talk about this interesting topic today, which is POP for all situations. That is very important for us to know that, we already are aware that our population is increasing almost from 1.39 billion, and we are still growing up on that. And, the factors which are really influencing, for a woman to take up a contraceptive pill is her personal preference. Sometimes when they are air hostesses, they want a contraceptive pill which is not time bound. It's not, because they will be flying from one zone to another zone, so they have their own preference. They don't want a pill to be taken every day. Then they also want to know how effective the pill will be for them, and the additional benefits which we get. If she was getting irregular periods, she wouldn't mind taking any medicine, any contraceptive pill which will help her in keeping her menstrual cycle regular. So the most important thing which is the risk factor, and we must be all aware of that. What postpartum advice do we always give our women? We always tell them, abdominal exercises, you must breastfeed your child, you must have a follow-up with if she had hypertension, she had diabetes, or she had any other issues. And lastly, we at times forget even to talk in terms of contraception. So don't forget that in a postpartum advice, the contraception is very important. That means A, B, C, D are all four important factors which are important for a postpartum advice. Now, what advice can we give them in the postpartum period? Sorry, the importance of that contraception is that the women who are breastfeeding, it is a public issue with them. They just think that, once I'm breastfeeding, I'm not going to get pregnant. The other thing is that the method chosen should not interfere with the lactation for them. We must be very careful of giving them the medicine, the contraceptive pill, which doesn't interfere with lactation. And also, we want to decrease the time period between the two pregnancies, which is very, very important. So, to prevent unintended pregnancies in the postpartum period, we know that women assumed to be protected from pregnancy for 4 weeks following a delivery. Always remember that only the initial 4 weeks following a delivery, the women are protected. But in a non-lactating woman, the first ovulation, the mean first ovulation we find, it's about 45 to 94 days postpartum. And the earliest ovulation is 25 days even after delivery. So remember that we've got to tell the women about that they must be very careful in a non-lactating, that this is the time period. So you must start any pill which we would advise them. The lactation does extend the postpartum fertility, but we are not very sure how effective will that lactation amenorrhea be in this woman. So the factors which determine the choice is the need for a temporary versus a permanent method, the infant feeding choice, is she going to continue feeding the child or she's not going to continue feeding the child, and to extent which the informed consent is made prior to the delivery. Always remember, don't at the table when the patient is in labor, when she's screaming, "Ab mujhe agla bachcha nahi chahiye," that is the time we're talking to them about contraception. I think the 9th month is really the last, is really a very good time period for them to understand what to take as a next contraceptive during that time period. So if we initiate the combined oral contraceptive pills, these are totally contraindicated in the first 2 to 3 weeks because of the VTE risk. The estrogen containing contraceptive pills are contraindicated throughout the lactation period because we find that it decreases the milk supply. The women not breastfeeding ovulate within 45 days, and the breastfeeding women start the birth control should be by 6 weeks maximum. So menstruation and ovulation can be unpredictable in a breastfeeding woman. So the timing of contraception initiation is very, very important. So what options do we have to offer these postpartum women? The option which we could offer is a non-hormonal, which we already know about the copper T, which was spoken by the earlier speaker also. The progesterone only hormonal methods are there, and then we know about the other hormones which are there. So the ACOG and the WHO, they both agree that women who are breastfeeding should not use COCs before 6 weeks postpartum. WHO also recommends that if possible, breastfeeding women further delay the COCs until 6 months, which I spoke about earlier, and the postpartum period, and concerns about their impact on the milk quantity as well as the composition of the milk. That's the reason why we talk about. Now, what does the estrogen do? The estrogen basically can cause, thromboembolic disease, can cause, is contraindicated in patients who are diabetic. It also is not recommended in non-breastfeeding women in the immediate postpartum period. We know that it causes even mild symptoms like headache, breast tenderness, mood changes. Also can cause, not to be given in women who have dyslipidemia, who are smoking, obese. So this is, a contraindication. And WHO eligibility criteria tells us that this POPs belong to 1 and 2 and not in the 3 and 4, do not use any method. So postpartum women who are not breastfeeding, they belong to the 3 and 4 category. Postpartum non-breastfeeding between the 21 to 40 days belong to the 2 to 3. Breastfeeding less than 6 weeks is category 4. Breastfeeding more than 6 weeks and less than 6 months becomes in category 3. So we have, the WHO criteria. Whenever we are in trouble of what to advise to our woman, it's always better to look up the WHO eligibility criteria, as well as we can also get into that wheel which we all know about. Now, the progesterones which we can use as a contraceptive pill are progestogens, gestogens, and gestogens. And other synthetic progesterones act on the progesterone receptors, and however, they have their own specific effects. used as a medication in managing a variety of conditions, including contraception and menopausal hormone replacement therapy, amongst the others. Pills that contain a very low dose of progestin, like the natural hormone progesterone, should actually be taken, and oral progestin pills, which are the mono preparations, which were originally given to the women. The highest risk of VT was seen in them. Estrogen can reduce the milk production, and the term mini pill, then they came very low doses and only inhibit ovulation in almost 50% of the cycles. So we do have, what are the options with us? We have progesterone only pills. We have depot injections, which is medroxyprogesterone. We have implants with us, which are hormonal, and we have hormonal IUCDs, which we call them as the LNG IUCDs. What are the differences and how can they be used? The depot injections, which is medroxyprogesterone, can delay returning to fertility in 18 months after it is stopped. So that fertility delay happens to be one of the things which are important, and it is associated with 3 to 6-fold increase in the thrombosis. Then implants do cause menstrual disturbances, they do cause headache, there is dizziness, and we do have IUDs, which can perforate at the time because it's a postpartum uterus. Of course, already one of the doctor was saying that they found that the copper T was floating in the bladder. But it can cause, in the postpartum period, it can cause perforation. There could be heavy bleeding because of that. Then let us see what all can we give them. The progesterones which are not going to harm the women would be progesterone. The POP pills which contain traditional progesterone could be levonorgestrel, and the concentration is 0.030 milligrams, continuous administration without pause. And even those desogestrels, 0.075 milligrams, continuous administration without pause. Now I must tell you about a very interesting case over here. There was this woman who took postpartum went to the doctor. She suggested to her this tablet, which is named as Sirazet to all of us. Unfortunately, the patient went on and on bleeding on it. Now what had happened was the doctor did not tell her that you have to take it at the same time. It has to be taken. If you don't take it at the same time, that missed period window is very, very small in these women. I mean, in this pill. So it's better that we shift on to something which is very new and which is going to help our women, and that is drospirenone, which has recently come up in a dose of 4.0 milligrams, continuous administration for 24 days and 4 days pause. Now, why do we do a continuous administration only for 24 days and a 4 days pause? Because then we don't want the estrogens to be increased. So that is one of the reasons which we are there, and we are all aware about the androgenic activity. We find that drospirenone has very little androgenic activity, has very corticosteroid activity. So I think the drospirenone is one of the drugs of choice which we do have, looking into all these which are there with us. Now, the traditional progestin combination, what does it do? How does it stop ovulation? How does it monitor the ovulation? By a simple way, by combination of the cervical mucus thickening, preventing sperm penetration, and reduction of endometrial receptivity, which prevents the implantation. The newer progestin, which is desogestrel and drospirenone, they also inhibit ovulation. So the newer POPs which we have is desogestrel, which has an ovulation rate of 1 to 2% only, while the drospirenone has an ovulation rate of only 0.8%. Now, what does it do when the pills are containing the levonorgestrel? Low inhibitory capacity after ovulation, taken within a strict 3-hour daily window, and a Pearl index is typical between 6 to 8 weeks, 6 to 8 only. while the progesterone only pill has shown to have conception rates comparable to that which we can compare with the condoms, where the rate is almost 95%. The progesterone only pills have 91%. Progesterone only pills has 95%. The levonorgestrel has somewhere around 77 to 81% of the conception rates. This is how, the progesterone is going to act. A lot of studies have been done. You can see the various studies over here, and what they are talking about is that abnormal bleeding pattern with an increased frequency of bleeding lengthens the cycle, breakthrough bleeding, spotting, and prolonged bleeding. Discontinuation in up to almost 25% of the users because of this reason. And additionally, they can cause acne, they can cause hirsutism, ectopic pregnancies also have been seen with levonorgestrel. The estrogen-free inhibitors of ovulation, and ovulation is considered to occur in 97% of the cycles. No clinical effects on the lipid and carbohydrate metabolism, which we saw in the earlier slide. Then the desonorgestrel POP, it elevates the menstrual migraine. A lot of women always complain to us about migraine, and it is menstrually there. That is because of the progesterone. One of the main reasons which we find is the progesterone. So this also increases their menstrual migraine, but it certainly reduces the pain of endometriosis in women who have endometriosis. And the missed pill window over here is that of 12 hours. Side effects are same as acne, weight gain, depressed mood swings. Then the high proportion of concentration in the bleeding pattern has been seen. They could be irregular in the beginning, but when you continuously use, they can, settle down. But the main complaint of discontinuation amongst the women happens to be the irregular bleeding. So we have a 4th generation POP, which is drospirenone, and which we know that it is a 4 milligram tablet available in the market recently, which even I've started giving to my patients who insist upon taking these medicines postpartum. They said, we'll not bother about an injection. I don't want an intrauterine device to be inserted. So we have started giving them. It is by the name of Dronis P. So very easy to remember. It is a novel synthetic progestin. It is analogous to aldosterone and structurally different from the other progestins. Now, how does it act? It blocks the aldosterone activity and it prevents the salt and water retention. There's no weight gain, no bloating, there's no feet swelling. May reduce even the blood pressure if being given to a hypertensive woman. So it has progestin action, it has anti-mineralocorticoid and anti-adenopoietic action, and it has also an anti-androgenic action. By a lot of activities, by it stops the ovulation, so it has a contraception method. Then it prevents the salt and water, so there's no weight gain, no bloating, and all those symptoms which the women keep having. The anti-androgenic is prevents the excessive sebum, so should not increase the acne which is there. Rather, it should lead to improvement in the acne. So nearly all women can use POPs safely and effectively, including the women who are breastfeeding, are of any age, including from adolescent to women over 40 years, have just had an abortion or a miscarriage or an ectopic pregnancy, cigarette smoking, regardless of woman's age or number of cigarettes smoked, have anemia now, but in the past, but now will not have it, but should be taken care of about the varicose veins. So whenever I give, even the COPs to a woman, I always tell them that in case if you have headache, dizziness, excessive vomiting, or, even any of these symptoms like migraine and all, please let us, or leg cramps, which is very important, leg cramps, we must, call them back to us. So I always tell all my women, whomever I give these hormonal pills for any reason for that. So what are the indications of drospirenone? It is indicated for women of the reproductive potential to prevent pregnancy. And how can it be used? Now, this is something, which is very interesting. Starting in females with no current use of hormonal, that is, you can start it from day 1. day 1 of the tablet becomes the first day of the menstrual cycle. Otherwise, day 1 becomes the day 1 only. You can even give it in case if it is postpartum relationship, where they are into lactation amenorrhea. Then take subsequent tablets once daily at the same time each day for a total of 24 days. 4 pill-free days are to be there, and these tablets, the packet which comes is always, dated. Day 1, day 2, day 3. So no tablet on the other days. Now begin each subsequent pack on the same day of the week as the first cycle, which we do it in all the other contraceptive pills also. Now, how is it to be used? The hormone administration regime, which we found out, is 24 days, followed by a 4-day hormone was chosen. Improve the bleeding control, maintain is the estrogen concentration at early follicular phase, preventing the estrogen deficiency. That is why that pill-free time period is there. Now, when to take it? At the same time each day, and that interval between should always be 24 hours. And the administration is 24 days, followed by 4-day hormone fill, and we know that the concentration is to be maintained well. If a woman misses, we must always tell her beforehand that if you miss the pill, if one white active pill is missed, take the missed pill as soon as you remember it and continue taking 1 pill a day until the packet is finished. That means we fix up a time. I usually tell my women, take it at 8 p.m. at night. If you're sitting with me and you suddenly remember that I forgot my last evening's pill, please take it immediately, but continue with your 8 p.m. still. But if she has missed 2 or more white active pills, then take the last missed pill as soon as possible. Continue 1 tablet daily until the pack is finished, but additional non-hormonal contraception backup should be there. That should always be laid a stress on. So when we look up this medical eligibility criteria, this actually POP pill falls into category 1 in most of the conditions. What are the contraindications to these pills? Known or suspected pregnancy, unexplained vaginal bleeding, breast cancer. Then the caution should also be used when prescribing progesterone only pills in a few conditions, like if she has any concurrent medication which can be metabolized, like the ATTs, the antitubercular drugs, or taking that ritonavir, women who have undergone the bariatric surgery because they might have difficulty in their absorption. The progesterone only pill is intended to be used for contraception in all situations, used in circumstances when the estrogen containing pills are contraindicated, and the traditional drospirenone pill has a 24-hour missed pill window, which is very, very important. So this is what I would, I wanted, I rather told Dr. Sneha that I want this topic because we must know about this drospirenone, which has come up as a postpartum, progesterone only pill method. Thank you very much, everyone.
Thank you, Ritu Joshi madam, for covering contraception in postpartum period very well. Madam has elaborated all these methods, starting from PPICD, progesterone only pills, then injectable contraceptives, and the newer 4th generation pills like Dronisp. This is very important topic for for all gynecologists. But one thing I have to share, madam.
Yeah.
One thing, I came across 2 to 3 cases in last 1 year where our neurologist friend or a neurosurgeon or physician, they are blaming us for starting using pills for some patients, and that patient is having some neurological complications. But we have to tell them that these low dose pills will not cause this type of complications. Yes, ma'am. That was one.
Yeah, the physicians also need to be aware of the use of the contraceptive pills, which are low dose and so good for our women. Yeah, we must somehow. I mean, I think we'll soon bypass China in our population. somehow or the other, with whatever available in this basket of contraception, we must use it. And we must actually motivate our women to use that.
Thank you, ma'am.
Thank you very much. Thank you,
ma'am.
Sneha, for inviting me over.
Thank you so much, Ritu. Indeed, it was a very, very innovative, I would say, very informative session. And thank you especially for that postpartum newer contraception. Thank you so much. I have already written who else can be the best person or the appropriate person.
Thank you, Sneha. Thanks.
Yeah.
Thank you.
Thank you,
Thanks all. Take care.
Yeah, chalo. Bye-bye. See you then. And please continue with the OPD. Yeah, thank you so much.
Thank you so much, ma'am, for this wonderful lecture. And thank you, Yadav sir and Seema Porwal madam, for chairing this wonderful session. We move towards the next, that is the last session, panel discussion on obstetrics hemorrhage. And for that, we have moderator Dr. Sneha Boyar madam. And madam is the managing director at Sukhakarta Hospital, Yavatmal. She is practicing since last 32 years. She has held 2 national posts. She was FOXI chairperson for the breast committee, and then in the GCM of ICOG. She has also received award as the unsung hero national Dr. S.N. Malhotra Award for her outstanding work in rural obstetrics. Dr. Duru Shah Distinguished Community Service Award, champion of FOXI for 2 consecutive years, and the Dhira Award. She was also awarded 2 awards by Government of India at the hands of the Governor of Maharashtra. She has had multiple articles, chapters, talks, orations, and keynote addresses. Madam has done a hurricane of work in academics. She is National Adolescent Trainer, National Expert UNICEF. She is peer review of the Jogi Journal. Then I am a Maharashtra State Chairperson and MPH Committee and Convener for the PCPNDT. She is Amogs Chairperson presently for the Emergency Obstetric Committee, and in the past she was for the Medical Disorders Committee. She is also working as the SAPOG member on breastfeeding. She is the founder president of Isopara Vidarbha chapter. She was president of the Yavatmal OBGY Society and founder clinical secretary of the OBGY Society of Yavatmal. She's life member of FOXI, IMA, ISAR, IAG, ISOPARAB, and Madam is contesting as Vice President for FOXI, and we wish her all the best from this platform, and we assure her that we are always with her for this. Our second chairperson, our moderator for today is Dr. Gorakh Mandrupkar sir. Sir is consultant and reproductive medicine consultant. She is at Islampur, and he's postgraduate in OBGYN, clinical research, medical legal system, environmental sciences, and Marathi literature. He is vice president of the Gestosis India Association and member task force national policy on PPH of Government of India. He is ex-member National Inspection and Monitoring Committee, PCPNDT, Government of India, and he has devised HDP Gestosis score, that is a tool for screening pre-eclampsia. And I here would proudly say that sir started his first CME on gestosis when I was the secretary for the Latur OBGY Society, and it was the first CME that was held over here. So we are very proud to have sir as our expert here today. Our panelist for today is Dr. Dr. Aarti Mantri, and I am very proud to say that she is my aunt, and she was past president of the IMA branch of Jalna. She was also past president of the Rotary Club of Jalna, Inner Wheel Club. Then she was president of the Jalna OBGY Society for 2 years, and she has worked on nearly 4,000 teenage girls from ZP schools for anemia detection and treatment. She has been awarded with multiple awards, Mahila Gaurav Puraskar Award, then Savitribai Phule Puraskar, Nari Shakti Gaurav Puraskar. She has been a faculty at many national conferences and has delivered talks on multiple subjects. And she is also the infertility consultant and director of the New Life Fertility Center, and it is the first fertility center in Jalna, and the first test tube baby center, the first ICSI baby, all were delivered in this hospital, and we are proud to have her over here. Our second panelist is Dr. Manisha Barmade. She is a consultant OBGYN at Barmade Hospital. She is past secretary of the Latur OBGYN Society, past secretary of the MPS
Manisha
Society.
will not be joining. She
Yeah,
just
ma'am, she won't be joining. So the next panelist is Dr. Ashwini Kubde. She is MBBS DGO DNB, assistant professor OBGYN at Government Medical College Parbhani, and she works at Aditi Fertility Clinic Parbhani. Then Dr. Manjusha Udhan madam, she is past MBBS from Ambejogai Medical College, DGO with gold medal from Ambejogai Medical College. She worked as a medical officer in Civil Hospital Jalna, and she has her own private practice at Sri Surgical Hospital with special interest in infertility and colposcopy. Our next panelist today is Dr. Vishal Mandare sir. He is practicing at Islampur. He is secretary of the Islampur OBGYN Society and a freelancing laparoscopic surgeon. I think Dr. Moses madam won't be joining us today. She's senior consultant from Jalna. And then Dr. Shruti Joshi. She has done MBBS from KEM Hospital, MS OBGYN from KEM Hospital, Mumbai. She is assistant professor at Sangli Civil Hospital and currently assistant professor at Prakash Hospital, Islampur. We welcome all respected experts, moderators, and panelists for this panel discussion on obstetric hemorrhage. Over to you, ma'am.
Yes, thank you so much, Rachna, for that mammoth job of introducing all of us. Without much ado, we go ahead straightway to the panel discussion, and we have our expert, Dr. Gorakh, and all the panelists.
Ajay Mane sir has joined, ma'am.
Ajay Mane joined, so we would be very happy to have his precious words as well. Welcome, Dr. Ajay.
Yeah, thank you. I'm so sorry for joining late.
Good evening.
Don't read that. Don't read that. Respected Sneha Tai, my elder brother Kiran, my younger brother Kalyan, I just on behalf of all of us from Maharashtra and Amogs family, I congratulate Kalyan Barmade for being elected as a president, and he has taken charge in Pune recently. From all of us, congratulations to Kalyan, and I wish to congratulate Sneha ma'am also in near future as a vice president Foxy. So best luck for that endeavor. We are always with you, and everybody will be helping to you. And I congratulate you and Rachna for conducting this webinar. So academic portion must go on, and you are doing it since so many years. I'm seeing you since 15, 16 years. You are doing the job, and Rachna has joined recently. She's also doing very good job. And Gorakh is there. He has developed 2 apps for anemia and gestation score, which are available free of cost for all doctors. It is very creditable job. Google has also accepted. So I congratulate Gorakh also. He is our younger brother. जरी त्याची दाढी थोडीशी पांढरी असली तरी तो माझ्यापेक्षा लहान आहे गोरख. त्याच्यामुळे लहान भावाचं कौतुक करायला नेहमीच आनंद होतो. स्नेहाताईंना माहिती आहे. आणि आपली अमॉक्स फॅमिली ऑलवेज देअर. आरती मॅडम, आदित्यला भेटलो मी परवा दिवशीच. आमच्या प्रोग्राम मध्ये बोललो होतो त्याला पॅनलिस्ट म्हणून. मी म्हणलं अरे किती छान स्मार्ट आहेस म्हणलं तू. म्हणलं आमच्या आरती मंत्री मॅडम तुम्ही नातेवाईक का? हो हो आई आहे म्हणे माझी. म्हणलं अरे भाई छान, ग्रेट. मलाही माहित नव्हतं. छान. सो कॉंग्रॅच्युलेशन्स टू यू ऑल्सो. छान मुलगा आता अंकोमध्ये मस्त काम करतोय तो. आणि दिस विल बी अ व्हेरी ग्रेट डिस्कशन. सो आय विल बी लिसनिंग दॅट. सो प्लीज कंटिन्यू अँड बेस्ट लक स्नेहा मॅडम अगेन फॉर युअर एंडेवर, अँड वी ऑल आर विथ यू. दॅट इज 100% शुअर.
बिलकुल. बेस्ट लक, शुभेच्छा, मत आणि प्रार्थना.
सगळं आपण सोबत आहोत. 100%. Thank you, Rachna. Thank you, Monica, and Prajakta also for inviting. Thank you. अच्छा, हा माझा क्लासमेट आहे प्रसाद मगर.
That is what we
ती लायब्ररी त्याची नाहीये, त्या वडिलांची आहे. त्याच्या मागे दिसतीये ती.
हॅलो डॉक्टर प्रसाद. थँक्यू सो मच. थँक्यू.
हा, आणि ते मी ती लायब्ररी ऍक्च्युअली बघितलेली आहे. मगर सर आम्हाला शिकवायचे. तर अध्यात्माच्या पुस्तकापासून तर आधुनिक रोबोटिक्स पर्यंत सगळे पुस्तक आहेत. आणि हे प्रसादच्या मागे दिसते ही एक बाजू आहे. अशी चारी बाजूला पूर्ण मोठा हॉल, चारी बाजूला भरून तेवढी लायब्ररी त्याची. किमान 40,000 ते 50,000 पुस्तकं असतील त्यांच्या लायब्ररीत. इतकी मोठी लायब्ररी आहे. खूप छान, खूप छान.
Good. We should visit it also.
Ma'am, we have missed the slide of Dr. Swapna Nilangekar. She has also joined as panelist, and I think we can share her slide once.
Yeah.
She is right now the secretary of the Latur OBGYN Society. She is obstetrician and gynecologist at Nilangekar Hospital, Latur. She has special interest in infertility, laparoscopy, and high-risk obstetrics. She is undergraduate from GMC Kolhapur and postgraduate graduate from MJ Medical College, Mumbai. She has fellowship in laparoscopy at Kandivali, Mumbai and Ahmedabad, and fellowship in IVF at Nadkarni's Hospital, Surat and Vapi. She has done various paper presentations and 2 publications in international journal as first author. We welcome you, Swapna, and sorry for that. The slide just missed in that rush.
Thank you so much, Dr. Ajay Mane, my younger brother, for your very precious presence and of course the very valuable words as well. Welcome, Dr. Swapna. We just continue with our panel discussion. So without much ado, we directly go ahead with the case discussion. So here we have the first case. I think Dr. Aarti Mantri. Madam, we start with you. We have this 5 months pregnant lady who is a primary gravida, and she gives history of bleeding per vaginum this morning at home. It was painless in nature without any cause. So it has stopped spontaneously. On further inquiry, she revealed that there was a history of spotting during early pregnancy. On examination, she is normotensive, non-anemic, per abdominal uterus size is 20 weeks, relaxed fetal parts are well palpable, and fetal heart is good, well heard. There is no bleeding at present. What is your provisional diagnosis, and how would you manage this patient? Madam Aarti Mantri. Please unmute.
Auntie,
Madam,
unmute
please
करो.
unmute. Click on the mic वर थोडं. रचना, तू सांग त्यांना.
हो, आंटी unmute करो आप.
Okay.
Now you are unmute.
Yes.
Yeah.
I think now I am audible.
Yes.
So
Please.
I will take 1 minute to express my feelings also. Dr. Sneha, Dr. Rachana Jaju, Dr. Mane Kurtukoti, and all. Actually, I have presented in so many conferences, but this is special for me because it is organized by my daughter and she has invited me. That's why it's special in my life.
Yes.
So not taking much time, I will move to academic. Okay.
Yes, madam. Please go ahead.
5 months pregnancy. The case presented is very clear and it clinches the diagnosis without, I think, investigations also. Definitely, we will go to investigations, but with 5 months pregnancy is a second trimester. Per vaginum bleeding, painless, itself clinches the diagnosis that it is not, it rules out abruptio placenta. Then it is at rest. So it's a painless bleeding. There is no question of contractions or threatened abortion, and it's intermittent in nature. On further, there is spotting during early pregnancy that indicates a faulty or abnormal placentation in early pregnancy. She is normotensive, non-anemic. Uterus 20 weeks, relaxed. It's a painless. Fetal parts well palpated, so it rules out the molar gestation. And no bleeding at present, it indicates it's a painless intermittent bleeding. And my provisional diagnosis will be a low-lying placenta. It may be low-lying placenta or it may be a placenta previa proper. With further investigations, we will rule out the things.
Yeah. So what investigations you would like to do for this patient just to come to the definitive diagnosis, madam?
The only clinch one investigation which will clinch the diagnosis will be the ultrasonography.
Yes. So as you said, this is like recurrent bleeding episodes which are only spotting. So this may be just the warning hemorrhages. But then as you said that it can be, the reason can be anything. As you said, it can be abrupt show, this, that. But then Can it be some bleeding disorder? Would you like to rule out the bleeding diathesis, and what investigations you would like to go ahead with?
Yeah, definitely. Routine investigations like hemogram, coagulation profile is to be done. So
Okay.
it will.
Yeah, so this patient
Easy
actually
diagnosis.
has only, we can say at this point of time, we can say only recurrent early pregnancy hemorrhage, maybe the warning hemorrhages of placenta previa. We're not sure that we can get the diagnosis on ultrasonography, but meanwhile, we got these investigation reports, and blood group is A positive, coagulation profile, whatever is done is normal, routine antenatal care NC profile is also within normal limit. Ultrasonography shows low-lying placenta, and the RP retroplacental hypoechoic zone is well maintained, and there are no anomalies. So, of course, this is most likely the low-lying placenta. So, I would just ask, I think Manisha is not there. We can, anybody can take up this question. Because she's bleeding right from early pregnancy, can we go ahead with prophylactic osteo-tightening? Should we go ahead with tocolysis? What precaution should be advised for this patient?
Once the diagnosis of placenta previa is confirmed by ultrasonography, there is no role of prophylactic osteo-tightening.
Perfect. That is the
And
message.
on sonography, we can rule out the cervical incompetence also by measuring the length of cervical canal.
Correct.
Role of tocolysis is also not
how much
so
it should be
academic.
how much it should be to come to label it as short cervix?
It should be less than 2.5 centimeter in length.
Right. And what precautions you want to advise to this lady?
We have to advise her physical rest,
to
avoid the sexual contact which aggravates the bleeding.
Right.
And we should inform her that whenever there is a slightest bleeding, she should approach to the hospital because it can turn into torrential bleeding anytime. So she should be aware of this symptom.
Correct. Yes, Gorakh, your expert comments, please. Please unmute, Gorakh. Please unmute. Unmute. Sahiti, is there some problem in unmuting? Mike.
Yes.
Mic icon वर click करा. I think Sahiti, why there is a problem? Gorakh is not able to speak.
Sir, please join with audio first and then unmute yourself. We can see only the mic button, but your audio is not.
Okay. So we will go ahead with the case. So this is actually early pregnancy hemorrhage, recurrent early pregnancy hemorrhage. We have tried to rule out other causes for the early bleeding. That is, the pre-existing bleeding, diathesis, bleeding disorders, maybe the coagulation disorders. And we have come to the conclusion that it is low-lying placenta. Madam Mantri has already talked to us that she should be given all the instructions not to lift heavy weights, not to have intercourse, internal examination. So she should be given pelvic rest as such, not complete bed rest. Okay. So
Am I audible?
Yes, Gorakh, go ahead, please.
Right. So, yes, here I would like to just make one comment, madam, regarding the osteo-tightening. Because I take this opportunity to discourage the osteo-tightening overall, because in many metro cities, especially it is a fashion to do the osteo-tightening of all IVF conceptions. So here I would like to discourage that methodology, because Mantri Madam has rightly said, even we have diagnosed something, then there is no role. And unless until there is short cervix, there is no role at all about the osteo-tightening. So there is nothing like prophylactic osteo-tightening for IVF and in such cases. That is number one. So
Perfect.
that message, I think, should go very firmly. And second thing is regarding exercise, as what you said, many a times all those IVF conception, because nowadays these cases, like PV spotting, PV bleeding, etc. Usually they come up with the history of IVF or ART pregnancies. And all the IVF women or ART pregnancies, they are being told to take strict bed rest right from day one till the delivery. So which is a wrong advice. And I take this opportunity to tell all the even patients and our colleagues, because many times it happens, they come with some file and it is advised that strict bed rest till 9 months. And we fear, if we stop this bed rest, what will happen and whether patient will sue to me or etc. So the answer is no. In fact, the strict bed rest will cause a lot of complications, and that's why it should be avoided. That is the message. Over to you. Thank you.
Yes. So that's the best message. Definitely, as you said, short cervix, that's the only indication for osteotomy, but not here at all. There's no role of prophylactic osteotomy. In fact, what FIGO says that even if you have short cervix, then the cervical cerclage and vaginal progesterone, they are equally cost effective. They have comparable results. That is one more message. And as you have very rightly pointed out, there is no role absolutely for strict bed rest. In fact, it is detrimental to this pregnant lady, and it will be only the pelvic rest. So what is the recommendation for early diagnosis? I think there is some problem with my network. I suddenly got disconnected. Let me join once again. Yeah, so these are the RCOG green top guidelines that you have to diagnose the low-lying placenta at the earliest, even if it is within 2 centimeters of the internal os. From that time, you have to keep a watch on this. And once it goes into the 3rd trimester, then of course we have to label it as placenta previa, and then the various degrees, or you say the classification of placenta previa. Now, how will you manage this patient further? That is what is the case question. Who will be taking up this? I think we can we request the panelists to please rename themselves. Dr. Mandale, Dr.
Yes,
Vishal,
madam.
yeah. Can
Yes,
you please go ahead with the management of this case? How will you manage this case? Only 20 weeks and recurrent pregnancy hemorrhages.
After confirmation of the diagnosis, we will continue this as a routine pregnancy. And if there is a USG diagnosis of placenta previa, then we have to advise for all the guidelines for the placenta previa.
Okay. So when will you plan her delivery? How will you decide? How will you prepare her? Meanwhile, whether you are expecting some hemorrhages in between, some emergency bleeding.
Yeah, if there is emergency bleeding, then she should report at the earliest. If there is no complications, then we should plan her delivery around 36 weeks of gestational age. With baby, for baby, we should give antenatal steroids and magnesium sulfate.
Okay. So, Dr. Swapna, do other panelists agree to this? Should we go ahead with this management? Dr. Ashwini, Dr. Swapna, we can see Dr.
Yes.
Swapna here.
We can ask the patient to be accessible to the hospital if there is acute episode of any hemorrhage. Otherwise, the pregnancy can be continued up to 37 weeks. And then after 9th month scan, we will have an idea whether the placenta has migrated up or
Is it during the 9th month or is it
no,
somewhere early?
We can do routine scans during 7th month or 9th month. But by the time delivery is advisable, if the placenta has migrated, then we need not worry. But if it is low-lying, then we may need to do her cesarean section depending on the grade of previa. And
Okay, so usually when does the placenta migrate? When do we say that the placenta has migrated? Is it during the first trimester scan, after the first trimester scan, when she goes into
after
second trimester?
16 weeks, if there is if the
Yeah.
placenta has not migrated, then we may label it as placenta previa
Yes,
if it is
yes.
in 5 centimeter from the os.
Yeah, in fact, there is a feeling that there are two schools of thought. Some people say that it's migration of placenta previa. Some people say that during early pregnancy, because of the full bladder, there is indentation on the lower uterine segment, and that is why the placenta appears very close to the internal os. But during second trimester, it doesn't appear so close, and that is why we say it is migrated. But all these pictures should be clarified by second trimester, right? So once again, you go ahead with the same management up to 32 weeks, and then you do the ultrasonography for confirmation of the diagnosis, exact location of the placenta, as well as the presence or absence of the retroplacental sonorescent zone. Because once again, you have to rule out the placenta accreta syndrome. Now, whether you will hospitalize her because she's having recurrent hemorrhages, so whether you will hospitalize or you will manage her on domestic basis. What do you do in your practice?
That depends on the grade and severity. If patient is not having active hemorrhage, then we may advise her to stay in the vicinity and come to the hospital. Even if there is slight hemorrhage, we may arrange for blood and keep her blood reserved in emergency.
Yes. Do we have Dr. Manju Udhan? Dr. Shruti Joshi?
Madam Udhan madam has joined. She's there.
Okay, yeah. If you can tell her to please put on her video. Okay. Okay.
Yes.
Yeah, Dr. Manju. So can we have a few comments from you on this management of this early pregnancy hemorrhage?
Yes, I think it is at around 20 weeks of pregnancy. Then we should take proper antenatal care of that patient and antenatal vigilance. And we should also inform patient that she should not ignore about the signs of this warning hemorrhage.
Yes.
And the patient should be in our touch. And if there is any bleeding, then we should tell her that if there is any bleeding, you should consult immediately. And when the mother's condition and fetus is stable, then we can discharge her.
Do you think that this patient is a routine case of for antenatal care, or she is a high-risk patient?
She is a high-risk patient.
Yes. So that has to be very, very clear that she is having low-lying placenta and she is having recurrent early pregnancy hemorrhages. So she is definitely a case of high risk, and she has to be kept under specialized care, and every time she has to be monitored, whether it is blood investigations or ultrasonography, as you said, the migration of the placenta, and of course the other things what you are trying. Now, when should you plan for delivery? What will be how will you decide for the timing and the mode of delivery? How do you do it routinely? That is what I want to ask.
In this case, if there is no active bleeding, and if mother is stable, and also the fetus is also stable, that means FHS are normal, then we can prolong pregnancy till 36-37 weeks. And after the fetal lung maturity occurs, and after this 36 weeks, then we can plan for cesarean section.
Yeah. So the recommendation is that whenever the mother and fetus, they are stable, your aim should be to pull this pregnancy to 37 weeks at least.
Yes.
And meanwhile, you prepare the fetus by giving magnesium sulfate for neuroprotection and steroids for lung maturity. We don't do any test for nowadays for lung maturity. But if at all, this is a patient who is having recurrent hemorrhages, right? And she's having low-lying placenta. So naturally, here our aim will be little short of 37 weeks. So at least till 34 weeks, we should try to plan this pregnancy. And then, of course, we have to plan for elective cesarean section, because it's a placenta previa diagnosis who is having recurrent warning hemorrhages. So you don't wait for her going into torrential hemorrhage, right? Okay. So we go ahead with the second case now. We have this registered second gravida para 1 with 9 months amenorrhea, and she comes to you with strong labor pains. Pulse rate is 100 BP, her vitals are okay, good. Uterus is full term, contractions are 40 seconds every 3 minutes, contour is well maintained, head is fixed, the fetal heart is 140 per minute. And patient started bearing down, spontaneous rupture of membranes with fresh gush of bleeding, and there is sudden drop in fetal heart. Okay, head is well fixed, she's bearing down, there is rupture of membrane, fresh gush of bleeding, and then the fetal heart drops. What is your diagnosis, Dr. Ashwini?
Hello, ma'am.
Yes. Yes, Dr. Ashwini.
Actually, she is term patient, madam. So I will see her previous scan reports, whether the placental locations, previous visit, any previous history of bleeding or not. And yeah, if placenta location is confirmed, then maybe it is
Yes.
related to
So,
the.
Dr. Ashwini, we tell you that she's a registered case. Her previous ultrasound reports are normal. She's as good as a normal pregnancy. Okay. And then she's into labor, progressive well. She's almost, bearing down. And then she gets a rupture of membranes.
Yes, ma'am. It may be abruptio placentae, madam, because of bleeding and the sudden fall in FHR, madam.
Okay. But then here the uterus is well contracted and you have adequate relaxation in between. Okay.
Yes, ma'am.
Correct. Huh.
Yes.
She is normotensive. So what can be the possibility?
Placenta previa only, madam.
No, anything else. She doesn't have placenta previa. The head is well fixed and she's bearing down. Okay. She's almost delivering, suppose, and there is rupture of membrane and there is fresh gush. That itself tells you, rupture of membrane followed by fresh gush of bleeding. Till before the rupture of membranes, the fetal heart was good. What is this very classical condition? It's called as vasa previa, rupture of vasa previa.
Yes.
Okay. So the only significant findings in this case should have been, the previous ultrasound report. Either it is, the placenta having some separate lobe, that is succinsurate lobe.
Yes, ma'am.
Or the abnormality in the insertion of the cord, the battledore insertion, and the vessels running in the membrane. That should have been mentioned. Okay, because it may not be from an expert, and that is why. Okay, so what is the differential diagnosis? As you rightly said, one should be abruptio placentae. Second can be rupture of uterus because she is having strong contractions and fresh gush of bleeding. Okay, so what should have been the now how will you manage this patient? Okay, active labor, fetal heart going deep down, and fresh gush of bleeding. So how will you deliver her? Caesar or vaginal delivery?
C-section, madam. As vaginal delivery, there is actually active bleeding is there, and fetal heart is also dropping. So there is no point for normal delivery management. We'll directly go for cesarean.
Yeah, suppose in this case she is already bearing down. That means she may be near full dilatation, right?
Yeah, ma'am.
So I think the answer should be we have to deliver her as fast as possible, by whatever modality, correct?
Yes,
Because for cesarean section you need to call the anesthetist, you need to prepare for OT. So that itself will take at least 15-20 minutes, even if you
side by side. Yes, ma'am.
Right?
Yes,
So
ma'am.
that is the answer, that you have to deliver this baby as soon as possible, by whatever modality. And I think if she is not near full dilatation, and if you have the arrangement for cesarean section at the earliest, you can definitely go ahead for cesarean section. Is there any way to prevent all this? Is there any, could you have diagnosed it earlier? How you could have prevented this possibility or catastrophe?
This condition can be diagnosed with color Doppler screening.
Yes.
And usually it's associated with low-lying placenta. Even if there is no placenta previa, whenever there is a low-lying placenta, we should rule out this condition. We should be suspicious about these vessels. And second, during clinical examination, if sometimes we do PV examination, we find pulsations.
Yes.
Yes, many times I felt pulsation, and whenever in some case we feel pulsations at the org, then we can convey the sonologist that concentrate on the os whether some vessels are crossing there.
Yes. Only thing is you have to keep it in mind that you are not, dealing with the cord presentation. Okay. You're not dealing with cord presentation. That also you have to make a. Okay. So Gorak, any comments from your side? Okay, I think Gorak.
Planned cesarean section in such cases is advisable.
Yes, definitely near
before the patient goes in labor.
Yes, near the term, you should go for ultrasonography. The moment you diagnose, you have to, plan her for cesarean section. Don't wait for going her into spontaneous labor. Correct? Okay. So, Dr. Manju, now we have this third case for you. We have a 32-year-old para 1 previous cesarean section. This lady, she's got one male child, 1 year old. She has come to you for the first time during 6 months with history of bleeding PV. Okay, bleeding. And when you inquire further, then she says that yes, early pregnancy also there was spotting. Our previous report, ultrasound report, shows low-lying placenta. When you do her ultrasonography at 26 weeks, it shows placenta previa, confirms placenta previa with absent retroplacental sonoglucent zone, and there is no anomalies. So I hope you got your diagnosis. So this lady at 30 weeks again, she comes to you with profuse bleeding. And the bleeding, she comes to you with history of bleeding. By the time she reaches the hospital, again the bleeding stops. So what is your diagnosis for this patient and how will you manage this patient?
As there is a painless bleeding and she is at 30 weeks, and her previous UG report shows low-lying placenta. Hence, my diagnosis in this case is placenta previa. And as in 26 weeks scan, as there is no retroplacental space, again it is my diagnosis is again extended with placenta previa with there might be the chances of placenta accreta or
yes. Okay, so how will you manage this patient?
As this patient is of 30 weeks, and when this patient came to my hospital, I will immediately see her vital parameters like pulse, blood pressure, and then I will start and I will admit this patient immediately. And
very clear message that low-lying placenta with placenta accreta, recurrent warning hemorrhages.
Hemorrhage may be occur, yes.
And of course, the special instructions what we discussed for placenta previa. Now you tell me, what is the difference in a plain placenta previa and placenta accreta? What is the difference in the management?
In placenta previa, we will plan for emergency cesarean section, elective cesarean section. But in case of placenta previa with placenta accreta, then in this case, we should be prepared for obstetric hysterectomy or cesarean hysterectomy.
Perfect. That is what the message is. So whether you should, now you tell me, how do you prepare this patient for the operative procedure?
In this first, I will admit this patient and do the basic investigation like hemogram, blood group, and coagulation profile. And blood sample should be taken for cross-matching and keep ready at least 2 to 3 units of PCV. Then in this case, mother is stable, and also I will do the sonography to know the recent location of placenta. Is there any separation or is there any retroplacental bleed? Also, we have to see this. And again, the sonography is for also fetal well-being, that whether fetus is in a well condition or not.
Okay.
Then after doing sonography, we should prolong this pregnancy till 36, 37 weeks. And during this period, we should give her corticosteroids. Betamethasone 12 milligrams.
Magnesium sulfate also. But before going to the management, what I'm trying to ask you, how do you counsel the patient and the relatives? Because it is such a serious complication of pregnancy, right?
Yes, yes.
So you have to discuss with the patient and relatives that what is your plan of management for this patient?
In this case, one should explain the prognosis of this prognosis of patient and the severity of the case. That is, in placenta previa, there may be chances of acute blood loss, and
Right.
patient may need ICU setup or in all these things.
Right.
And sometimes patient may need even hysterectomy also, or the
Yeah.
other surgeries like uterine artery ligation or internal iliac ligation.
Perfect. Perfect. What will you counsel them about this baby? Now it's only 30 weeks when she's having recurrent bleeding episodes.
Yeah.
How
But
will you counsel?
if there might be this acute hemorrhage or acute onset of blood loss, then there might be chances that baby fetal distress, or baby there may be chances of fetal death also.
Yes.
So
Yes.
that we should explain about the fetal condition as well as maternal condition to the
But then
relatives.
they will say, why don't you do cesarean section before the baby's death? Then how do you explain them?
Then, but at around 30 weeks, there is no maturity.
Yes. So that is what we have to explain them, that
baby
is
not salvageable.
Yes, yes. So we cannot assure you about the positive pregnancy outcome because the baby is too premature at present. If as long as she doesn't bleed much, we are trying to pull her up to maybe 34 weeks initially. But if at all she bleeds any time and she lands up into the emergency operative procedure, then we cannot assure you about the survival of the baby. We have to focus on the maternal survival. Okay, right. So that is how. Okay, so now you have reached maybe up to 34 weeks, but because now she is repeatedly having bleeding episodes, so you have to take her up for elective cesarean section with hysterectomy. Maybe that you have to take her informed written consent. Who all do you want along with you? You as an obstetrician.
I would like to add one thing.
Yeah.
If it is a placenta accreta, can we salvage the uterus rather than
We are
direct
coming to that. We are still in the pre-operative procedure. We are still on the counseling. Okay. We are still on the counseling. So who all do you want in your team? Tell me. When we discuss the operative procedure, we will discuss about it.
Yes, yes. In this expertise team, like expert anesthetist, obstetrician, and even with general surgeon and neonatologist,
yes,
should be there.
So
And facility of blood bank.
Yes, and
ICU backup.
ICU backup.
ICU backup and
hematologist.
Maybe a yes, blood bank and hematologist, blood bank and or hematologist preferably. See, you think of ideal situation. If at all given a choice, if you have a neurosurgeon, maybe a general surgeon, or maybe oncosurgeon, anybody. If not, even a plain general surgeon should be okay, because you need to dissect lots of, where the bladder and you may have to go for ureteric stenting as well, because sometimes you have extension in the retroperitoneal space also. Okay, so that is, so you may have to go for ureteric stenting pre-operatively, and somebody else, interventional radiologist, because to minimize the blood loss, you may go for pre-operative, what is called as, one is aortic balloon and second is uterine artery embolization. Right?
Yes.
So bilateral uterine artery embolization, or maybe bilateral, you have to go for the aortic balloon also. So that is possible with the help of interventional radiologist. So you have your team ready, you have your operative operation theater ready, you have your neonatologist with his NICU and your ICU for the mother ready. Okay, now you have blood and blood components ample ready, and you have the informed consent. Now your anesthetist team is perfect, you don't worry about the anesthetic. What kind of incision you want to take on abdomen? How do you open the abdomen?
In this case, I will open by taking vertical incision.
Okay, vertical midline incision may be the best, but even I think the phalansteal incision, the long or liberal phalansteal incision should be good enough. It is only, it should be liberal.
Yeah, it should be
liberal.
yes.
You should have lots of space to manipulate. That is why we say it should be vertical. But if you're well versed with the financial, you take the whole length of transverse incision, right? So you have lots of space. Now you see the uterus inside the moment you open. How do you decide which incision you want to take on uterus? On uterus, how do you take the incision for placenta previa accretum?
Yes, in this, I can take upper uterine segment.
Yes. Upper segment vertical.
At the upper segment.
Upper segment vertical. That is classical. That is one. Suppose you find, the whole of the uterus is so vascular that not only the lower segment, but even up to almost middle part. Then how do you take it?
Then initially, we can ligate the superficial vessels that we are seen on the surface of the uterus. Then uterine artery ligation.
Don't touch it. Don't touch it. You will waste your time because uterus, you touch it, you take a stitch or you try to ligate it, the more it bleeds. Okay. So for such case, you have what is called as transfundal, that is transverse fundal, because you are not bothered about the uterus. What you have to do is deliver the baby and see that she doesn't bleed. Okay. If you come and touch the placenta or incise the placenta, then that is a problem. So either it should be a vertical classical incision on the upper segment, or it is a transfundal. Just cut incise the fundus transversely, deliver the baby. And then the next precaution is not to touch the placenta. Absolutely no attempt at removal. Okay. So don't pull the placenta. That is one. Then what do you do? Suppose this lady has already given you, now this is a young lady, only one para 1 and 1 year old child. She says, Dr. May, whatever happens, I don't want to remove my uterus. So how do you decide? Suppose she is bleeding torrentially, then what will you do? You have to go ahead with hysterectomy. If she
uterine artery ligation.
Uterine artery.
Then internal iliac ligation. You can do it.
Yes. So this has to be done what is called as pre-operatively. Just pre-operatively, because if you have interventional radiologists, do it with the help of that. But if not, then what is called as triple P procedure. Okay. If the patient is ready or if she is bleeding profusely, then you have no option but to go ahead with fast obstetric. Only clamp and cut. In fact, you tie little later. Okay, so that you put the uterus and keep it aside. Okay. Suppose, she has to, she's insisting on conservative management, uterine conservative. Then what are all the procedures? How can you go ahead with the uterine conservative procedure? Anybody knows about triple P procedure? Yes, Dr. Swapna?
Uterine artery ligation, internal iliac ligation should be done.
Yes, that is called as stepwise pelvic devascularization. So that is one. So before that, we have already talked about what is called as placental mapping. You have 3P, okay, triple Ps. So first P is placental mapping. So either you do it with ultrasonography, expert sonologist with good resolution sonography will give you the proper information. But if the placenta is posterior or it is obese, then MRI. Then only MRI. Okay. So placental mapping is first step. Then secondly, it will be stepwise pelvic devascularization. And thirdly, when you make all this uterus totally bloodless, then you go ahead and cut because it's not going to bleed. So that is called as placental, that is called as patchy myometrial resection. Okay. So wherever you have only focal adherence, that you dissect out and cut it, and then you suture the myometrium. Okay. So that is called as patchy myometrial resection. This is the triple P procedure. This was done since long. Many people are expert in this. Now there is one more procedure which people are following, doing it very regularly. In Delhi, in Ahmedabad, there are dedicated centers where they are selectively managing only this placenta accreta spectrum cases. So what is that case? It's called as Amogs MG stitch. Okay. So here what you do is you ligate both the anterior division of internal iliac arteries. Then you take a very high stitch from both the sides of the incision, that is you occlude on both sides, and then you scrape out the placenta. Okay, so it doesn't bleed. If at all it bleeds, you take the underrunning stitches or you stitch it in layers. Okay, that is what is one more uterine conservative surgery. Otherwise, if the patient bleeds, if the patient is, elderly, if she has completed her family, and you find that, keeping this uterus is not mandatory, then of course it is very easy, you can go ahead. But even the obstetric hysterectomy for such cases, there is a high mortality as well as morbidity, because sometimes it just, oozes from everywhere. If at all, especially when you have the percreta, then definitely there is oozing from all around. So you must go for pre-operative. That means before starting the actual cesarean section, you have to go ahead with devascularization, pelvic devascularization. Okay, we have already discussed what is the role of MRI. All of you know what is the risk factor for placenta accreta spectrum. So any message, I think, do we have Gorak around? Can we have your message, Gorak? No, I don't think he's there around. So we can just give one message from here, one message from you, placenta accreta spectrum. How can you, Dr. Vishal? How should we
Yes.
try to prevent or maybe manage it well? Yes.
Yes, nowadays, as the previous cesarean section are on increasing side, the incidence is high. So whenever we see a patient of previous cesarean section, the sonography should be from a good sonology. If there is a anterior placenta, especially
Yes.
from a skilled sonologist, and it should then, if there is a confirmation of the placenta accreta, then it should be managed at tertiary care, preferably at the tertiary care with all the team.
Yes. So the moment you confirm the diagnosis of placenta accreta spectrum, you have to put her under care at a tertiary care center. We had actually requested for your comments. If you have any comments for this case, placenta accreta spectrum, please go ahead.
As you have rightly mentioned, whenever any patient of such placenta accreta spectrum comes, the first and foremost thing that we have to explain all the things to the relatives, to the patient, what are the possible complications which may occur. Blood transfusion, blood products, then even the decision may come that even hysterectomy also will be required.
Yes.
Or a decision may come where we are going to leave the placenta inside the uterus and we may come out. So many things we have to do. So all these things we have to explain to the patient and relatives and to tell them that such things should be managed, as Dr. Mandle sir has said, at tertiary centers. So it is always better to transfer such patient to the tertiary care center prior she goes in labor.
Right.
Let all things do in induction and in a proper elective manner. We should avoid the hassles, and then there will be no or low mortality and the morbidity. So all these things we have to explain to them. Over to you.
Yes, the message is very well delivered. I think all the panelists have contributed very well for this case. So we go ahead with the next case. Only for placenta accreta spectrum, what we have talked about, that the incidence of cesarean section has definitely risen over the years. So the only way to prevent is either you minimize the incidence of primary cesarean section, or you give appropriate or adequate trial for the secondary the patient for VBAC. And of course, if at all you land up into cesarean section, go for double layer, appropriate closure, proper closure. You go for decidual exclusion and go for double layer closure to ensure that the scar heals in a good way and not as a gutter.
Madam, here I would like to add one line.
Yes, please.
That whenever we are doing the primary cesarean sections, I have seen that की जे कोणी सिझेरियन करणारे आहेत त्यांच्यामध्ये एक स्पर्धा असते की मी किती फास्ट करतो. मी 20 मिनिटात केलं, मी 10 मिनिटात केलं. And in that, many a times it happens that they do the single layer closure.
Right.
There is no proper approximation. Only thing मध्ये आपलं धरायचं, ओढायचं आणि बांधायचं. So it has no meaning. And that's why it is leading to the abnormal placentation in a second. Otherwise, previously also people are doing cesarean sections,
That is right.
but the incidence has now risen. The reason behind even madam, you all seniors are here, you or Dr. Mantri madam,
Yes.
you all will agree that in your younger days you have used catgut.
Yes.
And there was microwave. But at that time this was not happening. But with the advanced suture materials, now it is happening.
Yes.
So it is not only the suture material, but it is the technique.
Yes.
आणि घाई अति घाई मसणात नाही अशी एक मराठीमध्ये म्हण आहे. So that is, I think that is.
Yes, it
leading
holds true even today. And
That
even today, I can tell you that, Gorak, even you will agree, I think, you can look at this incidence of placenta accreta spectrum. Even today, it's highest in the metropolitan cities.
Absolutely,
See,
absolutely.
in this region, we have rarely seen a case, rarely. Once or
Absolutely.
twice a year, maybe once a year or so. So managing 20,000 cases of delivery, I have faced only one case of placenta accreta spectrum, that too in recent years. Yeah. So I think definitely what you are saying, proper time that is required and a proper technique is required, that we have to definitely go for it. So that's a very good message, practical. Thank you so much.
Definitely. I agree with Dr. Gorak, but I would like to highlight one point with my experience of last 37 years, that
Right.
many times whenever a case of placenta previa comes, we should always try to rule out the placenta accreta. Many times radiologists miss it. And on section table, when we take patient for section, that time we find that it's adherent placenta. This happens. So we should have one or two expert opinions, and if required, transvaginal sonography of MRI should be done to rule out the placenta accreta, percreta, increta, whatever intensity is there, and accordingly we have to manage the case. And the second thing is we find patchy accreta.
Yes.
Many times placenta previa is not there. Placenta is at normal position, but a part of placenta is invaded and it's adhered. This emergency also many times we face.
Yes.
So
That
we
is
should
why-
have a good location or good look at the placenta.
Yes, yes. So that is why recently, yesterday only, I delivered a talk at Agra, modern management of placenta accreta spectrum. Here we have to stress on right from early pregnancy, even at 6 to 8 weeks, you can, suspect by transvaginal sonography. If you find in a case of previous cesarean section, a low-lying gestational sac anteriorly, that itself, raise your antenna high. And 11 to 13 weeks, when you go for all these, uterine pulsatility index, CT scan, etc., there you have to go for placental localization and in search of the retroplacental sonolucent zone. So that is how, you have to keep the high index of suspicion and spatially search for it to come to the diagnosis or rule out.
It will be a preventive approach.
Yes. Yes, and that is how, even the proper closure of uterus, what we are saying, that itself is a preventive approach. But then definitely you can diagnose at the earliest when you have the ultrasonography with expert sonologists and good resolution sonography. If at all you have all these problems, you can go ahead with MRI to confirm. And then, of course, you have to follow all these management protocols, what we have discussed. Yes. So, Dr. Swapna, we have this case for you. Now, I think this is the last case we will have. We have this 20-year-old primi gravida, 9 months amenorrhea. She's referred to you at 11 p.m. at night from a nearby small nursing home. Okay, she was admitted here in a small nursing home since last 8 hours, and she was in labor for last 12 hours total. So she was having a strong uterine contractions, but absolutely non-progressive labor. So they decided to take her for cesarean section. The sister, as usual, catheterized bladder. She saw no urine. So she asked the patient when she had passed. So over last 12 hours, she has not passed urine. Okay, so I'm sure you're getting the diagnosis.
Yes.
When this patient comes to tertiary care center, her vitals, pulse rate is 110, BP is 110/70 still. Uterine contractions are so strong in intensity, there is absolutely no relaxation. Fetal heart is 120. Her cervix is 3 centimeter dilated. Membranes are absent, station 0, and there is a fresh gush of blackish color bleeding. And when we sent her investigation, the reports are hemoglobin 8 gram%, platelet 1.5 lakhs, PPINR 2 and APTT prolonged. Fibrinogen degradation products were present, and fibrinogen was 150 milligram% only. So what is your diagnosis and how will you manage this case?
It is a case of abruptio placentae, since the patient is having severe abdominal pain, strong uterine contractions, that is, the uterus might be tense, tender, and tonically contracted, with anuria. She's having anuria because of shock. Her parameters are pulse raised is pulse is raised.
Indicator of that.
Then all the coagulation profile is deranged. HB is 8 gram, and there is slight bleeding outside, but she is profusely bleeding inside. And fibrinogen has been used up. PTINR is deranged. APTT is prolonged. So she is having severe abruptio placentae with renal failure with deranged coagulation, DIC. Or
and for fetus? For fetus?
Sorry.
Fetus?
For fetus, the heart rate is 120 per minute. So, but the prospect of vaginal delivery is not so near, because it is only 3 centimeter dilated.
Yeah.
So, she might have a fetal distress. 120 is
so now
on the
my
lower
only question is whether you
side.
want to take her up for cesarean section immediately, or you want to wait
First,
for
we
blood
will have to stabilize the patient.
Hmm.
Since the patient is in shock, we may have to restore her volume with crystalloids. We have to arrange for blood and blood products. And by the time everything is arranged, her volume is stabilized, then we will take her for cesarean section. Also, for renal failure, we have
What
to.
about the fibrinogen and FDP? She's already in DIC, early DIC.
Yeah, she is already in DIC. We have to give her FDPs and FFP, sorry, FFP cryo, and if at all needed, platelets.
Okay. Platelet, no, 1.5 lakhs, more
Yeah,
than
1.5 is fair enough. Blood and
cryoprecipitate and FFP.
FFPs needed to be given.
Right. If not available or getting ready, by the time maybe packed cell volume or fresh whole blood.
Whole blood or whole blood may be given in this case, since it may have other coagulants.
Right. So, what precautions you should take for during as we have already discussed rest of the aspects. Now she's got severe abruptio with fetal distress. You have taken her for cesarean section. You have stabilized her, put on 2 IV cannulas. From one side you are fast giving fluids, other side you are sending the lab, keeping for blood transfusion ready. So what is the aim of you are saying stabilizing. So what do you mean by stabilizing? What are your targets for therapy?
The targets are to restore her volume initially. Then stop her coagulation cascade that has been deranged, and give her blood. And at the same time, we have to deliver the fetus as soon as possible and stop the source of bleeding.
Yes. Perfect. What about the uterotonics?
To prevent postpartum hemorrhage, we have to give her with uterotonics,
because she's very prone for PPH, no? Already abruptio, coagulopathy.
Yeah.
So what?
And slight bleeding may lead to more derangement of a situation. So we have to manage that prophylactically for PPH.
Right. So we have lots of details about this FFP, how much to be given. We will skip that. Our aim should be to correct the hypovolemia, because she has landed up into anuria, that is acute tubular necrosis. We don't want that is a reversible renal failure. We don't want her to go into irreversible renal failure, that is the acute cortical necrosis. And for this, we have to go for aggressive fluid resuscitation, blood and blood products, so that her GFR is improved and her urine output is improved. It comes to 30 ml per hour at least. At least she should start getting urine output, right? That should be our aim of therapy. So rest is you have already talked about. So I think these are few. There are many good cases, but I would just stop here because of short of time, and we have lots of details about these cases also. Only one case last. I want to give one message here for this. No. Yeah, I think, yeah, we will. For actually, I have one very good case, but later on we will discuss sometime later. So I just take this opportunity to thank first and foremost all the 4 societies, Latur, Parbhani, Islampur and Jalna societies and their president and secretaries. I have personally thanked all of them. I thank you all the panelists, who have actually added value to our discussion. So thank you one and all. And I just take this opportunity to request all of you to vote for me. I'm your own representative and I'm contesting for Foxy Vice President from West Zone. There are 2 posts, but just make sure that all of you vote first place. You vote for me and make me win. I want to win with your support so that I can work for you in future also. So thank you so much all, one and all.
Definitely, ma'am. And thank you so much for this wonderful CME and this panel discussion and for inviting us, ma'am. Our support is with you, surely, ma'am.
Thank you so much.
Thank you very much, madam, and wish you all the best for your tenure. And I'm directly declaring that yes, you are going to become vice president of the Foxy.
Yes.
And all Maharashtra is with you. And thank you very much for this today's webinar. And I congratulate Dr. Jaju madam as well as Dr. Umardhan madam. Thank you very much.
Thank you so much, Gorak. Thank you for your valuable inputs as well. We are very happy to have you. Thank you, Gorak. Thank you, Dr. Rachna and Dr. Monica, for all your hard work, for bringing everybody together. And thank you, Dr. Prajakta. I think Prajakta is not able to join because of some emergency. So thank you, everybody, Dr. Vishal Mandare, Dr. Swapna, Dr. Manju, Madam Aarti Mantri, and everybody. Thank you so much. Thank you so much.
Thank you, Sneha ma'am, and thank you, Rachna, for inviting me as a panelist.
Thank you, and I wish you all the best and a great future, academic future ahead.
Thank you so much, madam. We need your help. Thank you.
Thank you all for joining in today. It was an excellent panel discussion with very delightful insights and a crisp and clear take-home messages from all the panelists. We are very much obliged to all of them. And thank you, one and all, on behalf of the Amogs Emergency Committee and Amogs MTP and Family Welfare Committee, Kiran sir, Mane sir, Baramde sir, all our esteemed chairpersons, our panelists. Thank you so much.
Yes, and our speakers, Dr. Ritu and Dr. Meeta, who have all the way joined from Jammu Kashmir and Jaipur, Rajasthan. So we're very happy to have them. Thank you. Thank you, Rachna. Thank you, everybody.
Good night. Good night.
इलेक्शन्स जवळ आल्यावर आम्ही थोडं रिमाइंड करू तुम्हाला. मधल्या वेळेस आम्ही फारसं डिस्टर्ब नाही करणार तुम्हाला. आम्ही आपले उमेदवार आहोत. लक्ष ठेवा. नमस्कार. धन्यवाद.